welcome everyone. Welcome to the annual public meeting of the Riverland Mallee Currawong Local Health Network. I do just want to start by acknowledging that here in Tailem Bend we're on the traditional lands of the Ngarrindjeri people, and want to acknowledge them as the traditional custodians whose Aboriginal lands we're meeting on here today. Want to pay respect to their elders, past, present and future, and acknowledge their deep feelings of attachment to their country. And I also want to acknowledge the cultural authority of Aboriginal attendees from elsewhere in Australia who are with us today, either present here in the room or online via Facebook, which we're webcasting this event to. Now we'll just advise people that there are photos in the presentation behind me, and there is a chance that the presentation may contain some images of Aboriginal people that have passed away. As I mentioned, we are live streaming this via Facebook, and so when we open up to questions, we'll be receiving questions both from the floor here in Tailem Bend and online later on. So just a little bit about the Riverland Mallee Currawong Local Health Network. We support a population of around 70,000 people really living along the entirety of the length of the Murray River as it passes through South Australia and all of the Mallee area of South Australia to the east of the river. This includes obviously towns like Renmark, Puringa, all of the towns in the Riverland, Waikerie, towns in the Currawong, Tailem Bend, Tintinara, Canalpin, Meningie and so on, as well as Murray Bridge is the largest centre in the region, and of course the towns in the Mallee, Karoonda, Pinnaroo, Lameroo and so on. So we offer a wide range of health services to each of those different communities, different scales of health services and different configurations of health services, really aimed at meeting the needs of all of those 70,000 people. Including accident and emergency services, Aboriginal health services, mental health services, obstetric gynecology services, and a whole range of different aged care services, both in people's own homes and of course in health facilities. Yeah, I'm going to just advise people really that there are minutes available, and if anyone's after a copy of our minutes from the previous meeting, they're available in the room here, up at the area where people walked in. And really just want to note those minutes here. We don't have to formally move them.
No, they get moved at the next board meeting.
They get moved at the next board meeting tomorrow. Yep. And having noted those minutes, I will hand over to Dr. Peter Joyner, our board chair.
Thank you, Wayne. I'll try to outline the significant history of our organisation, and behind me we'll present a series of slides which will be far more informative than whatever I say. So I'll try just to speak as we go through rather than just read from them, which I think is always rude. I'd like to also start with acknowledging the country meter, the Ngarrindjeri country, and pay respect to the elders, past, present and emerging, etc. Now those words I've often said, but going to Raukan, being able to take part in the NAIDOC celebration of Meningie really gave all of us on the board a much deeper sense of understanding of what it means to be an Aboriginal person living on the land that their ancestors lived on for generations. So we found it a privilege and we welcome that, and as I said, it means that whenever I say those words it actually means more to me than maybe I would have realised before, because I hadn't had that experience. Okay. The governing board was decided by the previous, government coming here, the previous government, that they had a wish to have rural areas represented by regions which would respond to people locally, and this was an established process, and the Minister at the time wanted to have a skill-based board, not a representative of a nurse, a doctor, or whatever. So although I happen to have been a doctor, I'm there in a different capacity as hopefully bringing my understanding of the region to bear. We self-evaluate our process. We have committees. We have Finance Committee, Governance Committee, and we've recently taken a Aged Care and Disability Committee to focus particularly on that part of our activities. We have achieved a lot through this time, and these are some highlights. The COVID response has been a pressure on everyone, both simply being able to turn up to work if you have had COVID, someone in your family hasn't, or someone at work. And work pressures right throughout our region have been enormous. Today we're discussing just how much our staff, in every capacity we employ them, have gone further than they need during this last year or so. Because when you're tired, you've been ill, you're stressed, it's very difficult to focus. So we really publicly want to thank all our staff for their hard work that they've done. And in addition, we obviously had the COVID response at Rocket, which was a dramatic example of people going above and beyond their duty. They had nurses there in full PPE all day, walking up and down a hill to deliver services in a 37-degree temperature. Now, we've provided them with an award from our own internal awards, and they've been recognised elsewhere. So it's just an example whereby a particular special group of people who weren't trying to be different, who didn't want anything different for themselves, were very happy that we could provide service in their own environment, which is a critical factor. In addition to that, we've got the Riverland Academy of Clinical Excellence. And I was discussing with Professor Paul Worthy just a few minutes ago. Workforce shortage across all of South Australia and across Australia is a factor. Nurses, doctors, aged care workers, everyone. If we wanted to have people come in being able to become well-qualified rural generalist doctors who can go into country areas and work effectively and properly, this is a method of training them. It is underpinning by the fact that it's not just a simple structure training doctors. We have teaching, we have specialists involved in that, we have GP specialists. It's also a high research component which attracts a cohort of people who are interested in doing research. And at the board meeting today, we had a list of all the research projects currently being undertaken, which underpins the authenticity, gives us worldwide recognition. It was presented, Wayne was able to go to Wonka in Ireland to present it at the international conference. So we're doing there, which is not being mirrored anywhere else in South Australia or perhaps elsewhere at the moment. We've also established at Berry and Loxton now a midwifery support process where instead of the traditional model where midwives work in a hospital on shift and that's all you do, whoever comes in, you see, you treat, you go home, they are dedicated to looking after women in pregnancy. So ideally one midwife and one forms a relationship with a pregnant woman, sees her through the pregnancy, is able to be there when she's in labour and help with her delivery, for continuity of care, which provides a better outcome for the woman involved and certainly the midwives enjoy. So I'm being kindly directed to stand in a different area, so pardon me, I'll do that. We've also extended the emergency care unit at Riverland General Hospital, and people who have seen the artwork there, in addition to the artwork as we have at Murray Bridge ED, which is a tremendously brilliant example of Aboriginal art. We've done many other things, and we've hosted the inaugural Combined Health Advisory Council Conference here just out on the race course there, which is brilliant. We've now continued our process of an operational plan. I won't take up too much time, but when you have a complex organisation, and Wayne addressed some of the things that we're doing in hospital, out of hospital, community, mental health, Aboriginal, midwifery, a whole range of things, you need to have a well-organised plan with achievement, with guidelines. and we have completed our first year of our operational plan. We've also organised a support teleconference facility that supports EDs in smaller hospitals across our region who aren't always able to have doctors on hand. That's run through Mberry through the process we've established with Race there, the academy. That's another example where if you do things properly and underpin it, you can extrapolate them across the region, which is what's happening there. The hub and spoke CSSD, one thing I found in medicine and in health is there's always change. Every time you think you've got something that's up to standard, they bring a new standard in. And this has happened with sterilising aspects. The hospital, which was built not that long ago, top of the grade at that stage, now is not considered to have the right degree of sterilisation components and is having to be rebuilt to provide that. And we're going to have a hub and spoke model whereby all the sterilising process to the highest standard is done there and then can be taken out to the other hospitals where they're required. And that's one of the facts we face in life. There's always higher demands than we anticipate. We certainly celebrated our awards and included NAIDOC awards as well. And there were some photos here of various people involved. These are all at our celebration at the top area, and then other people who have been involved there. So COVID has presented a challenge, and we hope that it's not gone away, but that it will be more handled more appropriately, if you like. We've got plans and strategies for the future, because the one thing you can't afford to do when you are in an organisation like ours is assume that you know everything, you've done everything, and then nothing's going to change. There's three wrong answers. We don't know everything. We don't know everything at the moment. We certainly don't know what's going to happen in the future. And we need to be aware that change is the only constant factor. How we deliver health challenges, it's only a small challenge, but Japanese encephalitis now has been identified as a problem up and down the river. Not maybe a huge problem, but no one would have just thought about that a few years ago. We've relaunched our clinician and workforce engagement strategies, community engagement strategies, disability access and inclusion plan. Examples listed there of the various plans that we have undertaken to try to address separate areas. If we come to the future, we've got challenges and areas of focus. Obviously, we've had the COVID-19 pandemic. It's moving from coming into the country in that early phase. It's now endemic, and there will be constant a rise of new mutations. And it's anticipated there'll be another influx of cases possibly in December time. And even next year there'll be different aspects of who knows what other viruses are around the corner. So we've got to identify, manage, treat, vaccinate, a whole range of issues which we have to continue there. I've mentioned Japanese encephalitis, which seems to run up either side of the Murray, maybe 5 k's, and again where there are piggeries is a high risk area. The Central Public Health System in Adelaide is coordinating that, and we're helping them to provide that process, and there'll be much more publicity about that in the next 2 or 3 weeks, I understand. Aged care accreditation is an area which is becoming an increasing focus. You pick up the paper, and if you're at all interested, you would realise there's been a huge focus on aged care, with unfortunately some terrible aspects been highlighted in the last few years, but now given rise to the federal government's examination and a whole range of standards, expectations, etc. now coming, so that into the future there'll be things like a STAR system which will give aged care a grading for the public to see. There'll be expectations of standards of how many nurses work at over what time in various areas. There'll be the ability of people to complain quite easily and relatives if there's a concern. So from our point of view, we take that as a challenge to provide high focus are focused rather on high quality services. We don't want to do anything other than the best for people. We have to balance the fact that in a region such as ours, there's a diversity of people, a diversity of needs, and a diversity of location. So what we can possibly achieve in Berry or Loxton may be difficult to achieve in smaller areas, but we will always strive to achieve the best possible outcome for individuals wherever they happen to be. And that's going to be something which won't be resolved quickly. I think it's going to be a process at least the next few years while we come to a full understanding of what's required. Other challenges and areas are staff recruitment, retention and wellbeing. Every person in the health parameter is in short supply. Doctors, nurses, aged care, it doesn't matter who you like to say. And depends on which bit of the paper you pick up. General practice is struggling. I think in a country it does a better job than maybe in the cities because it has a wider parameter, a wider exposure, a wider commitment, but it's not without problems. But we need to be able to continue to grow our own workforce with retaining as many people as possible, becoming attractive for people to work for us. And just the other day we had a discussion with the Minister about our ability, or so far lack of ability, to really advertise and really be positive about bringing people into this area, be it Murray Bridge, Meningie or North up in the Riverland, and he agrees that we should be more liberal in that aspect, so that's a good positive sign. We've obviously race, as I said, is our continued expansion of that. Our RMC Cares, the TV support telehealth system. We've had an inaugural staff survey and we are actioning that to try, as I said tonight, to provide the best possible employment conditions. I think I've come to it. Wayne is happy now because he gets a chance to present some of his comments, but thank you all for coming. It's often hard for me to provide a total coverage of all we're involved in without boring you witless or just reading stuff, but I hope it's given you an understanding of the complexity of health delivery services, but our wish to rise to that challenge to deliver the right services for people in the room here and all their other people in our region. Thank you.
So I'll just give people a brief overview of some of the activities in the last financial year. In the last financial year really has challenged the resilience of our workforce and been a year of considerable change and lots of challenges with COVID-19, with the borders opening, state borders opening, international borders opening, whole lot of restrictions in place as we went through what we thought was going to be the Delta wave of COVID, then the Omicron BA1 wave of COVID, and then the BA2 wave of COVID, then the BA4 and 5 wave of COVID, following on from the border opening. And we're still grappling with COVID-19 and slowly normalising living with COVID as both levels of population immunity have improved through vaccination and the level of general awareness about hand hygiene, physical distancing, room density and so on has allowed government really to push responsibility back onto individual citizens instead of taking that responsibility and putting a whole lot of restrictions in place. It's also been an exciting year with some of our initiatives, and in particular one that I'll talk about later, Riverland Academy, clinical excellence, a whole lot of innovation and so on. But we'll start off just by talking a little bit about COVID-19. And just want to acknowledge the huge effort that all of our workforce have put in place in order to respond to COVID-19. It has been tremendously scary for frontline health workers, particularly in the early days when people were dying en masse overseas, the borders were locked down, but you didn't know whether someone coming in the door had been exposed to COVID-19 or not, or you didn't know if you were providing community health services into someone's home, whether that person might have been exposed to COVID-19 or not. And it, takes a bit of time to build up confidence with PPE and some of the procedures that are in place to protect staff from COVID-19. And I can certainly remember being with clinical staff when we received our first COVID-19 patient at Riverland General Hospital. And, they were legitimately scared for their own welfare whilst trying to also provide the best possible care for that patient. Now, of course, Riverland General Hospital is a COVID accepting hospital, and it's routine to provide care to COVID positive people. It's a normal routine activity, but it was terrifying for people that first time round, and really just want to acknowledge all the staff that have put themselves in what is quite a precarious and stressful situation in order to care for their community, who are also going through a very precarious and stressful situation. Now, we have delivered a huge range of services that we would have never provided without COVID-19. Everything from PCR testing through to now distributing RAT test kits, through to providing care into people's own homes when they're COVID-19 positive, supporting people to isolate at home, establishing a temporary accommodation facility for COVID positive people in the Inala units across the road from Riverland General Hospital ourselves. I personally led the planning and coordination of the COVID response across all of regional South Australia, 61 health services and all 6 regional local health networks. We implemented monoclonal antibody treatments across all of regional South Australia, and in our case at Riverland General Hospital and Murray Bridge Soldiers Memorial Hospital. We provided those services, that access to those services to people in vulnerable Aboriginal communities when they were unwell with COVID-19, and to any other community members from our region that qualified for them. We've also adapted and adjusted COVID treatment pathways for high-risk consumers, such as those on renal dialysis, pregnant women, and so on. And there was a stage where everyone in those categories that was COVID positive was considered to be at such risk that they had to go to a tertiary hospital for care. Now much of their care is provided here in their own region, close to their own home or in their own home, through their pregnancy or through their dialysis treatment in the time that they also have COVID-19. If they happen to be going to labour when they've got COVID-19, then they still go to a tertiary centre ideally. And of course we led the response, as you've heard about, to the COVID-19 outbreaks in Rauken and Draab, 2 designated Aboriginal communities in our region. And we did that in a way that really partnered with the communities, respected the communities' wishes, and prevented a whole lot of unnecessary transfers to Adelaide, which was the model of care for vulnerable Aboriginal communities at a statewide level at the time. And, that's acted as a catalyst for the change in the way Aboriginal communities are treated across all of regional South Australia now, in the case of COVID-19 outbreaks. I do have some photos, Peter, of different people doing different things, mostly related to COVID-19 and some of the activities involved, but we'll just move on to the next slide. I want to talk briefly about the Riverland Academy of Clinical Excellence. So the Riverland Academy of Clinical Excellence, or RACE, is our platform for clinical teaching and training, for research, for innovation, and for changing the culture of our clinical workforce. And in the past year, we've established a medical educational unit. We've gained accreditation to provide medical training for, really the entire pathway from graduation with a medical degree to graduation with a fellowship as an independently practicing rural generalist or GP. And we have, established a whole lot of processes and training opportunities for clinicians throughout the whole of the organisation along with that pathway. So, you know, the fact that we now have 15 junior doctors involved in training in our organisation and more coming in as different years of the program fill up, you know, the cohort that was in year 1 moves to year 2 and we have a new cohort coming in at year 1, really has meant that we've become very attractive to GPs and to doctors as an employer. And so, you know, we are bucking the trend, spending about 1/3 of as much money as our partner regional local health networks on medical locums, because we've been able to attract doctors into working in our health services, both through the opportunity to be involved in training for senior doctors that were our GPs in our communities, have worked in our hospitals over many years and have often felt under-recognised and under-rewarded. Actually, the opportunity to be involved in training, to be recognised for their clinical skills, has attracted some of them back into our services. And at the same time, of course, we're attracting new entrants, you know, into as interns, junior doctors, and then registrars in our health services right throughout the whole region, on placement in different hospitals throughout the region. And that questioning of, you know, someone seeing things for the first time, asking a senior doctor, you know, why are you doing this? When I did my course, we learned about this, how does that relate to it, whatever. Actually helps sharpen both the teachers, the supervisors' skills and experience, as well as the students. So really what that means is that it's lifting the performance of the whole LHN, not just training the new doctors coming in. That, you know, recognition of patient enthusiasm for the medical workforce is a bit infectious. So they've got an interest now in research, got an interest in developing other parts of the clinical workforce. We've held an emergency care and advanced skills and anaesthetics conference, and really RACE has acted as the catalyst for all of that, as well as being world leading. And you heard before I presented on it at the World Rural Health Conference in Ireland earlier in the year, in terms of providing certainty of employment for trainees from graduation with a medical degree through 5 years of training to fellowship as a GP or a rural generalist. We are one of only 2 health services funded to have a training program where state government employees employed at, you know, on a continuous employment contract with the state government can be placed into GP practices, bill Medicare as a medical trainee working a GP practice on a GP training rotation, whilst they're state government employees. And that continuity of employment really makes the program attractive to trainees, because they don't have to. You think about someone, you know, who wants to become a doctor and is passionate about becoming a GP, they don't have to give up the state government employment arrangement which they've had as an intern and a junior doctor, which they've had to be before they then become a registrar. They don't have to lose their super scheme, they don't have to lose their leave balance, their sick leave balance and all those sorts of things by changing employer, going from a large stable government employer to, in some cases, a very small local business GP employer. Which is, you know, part of the attraction of the RACE program to trainees. We've introduced a Grand Round series, and that's available. We make it available on the internet. We make it available globally, really, to anyone that's interested in looking at it, where we invite keynote speakers really from around the world, generally around Australia, but we line up some international ones as well, to present on their experience of rural health services or medical training or any of those topics that are important to us as a local health network. And, you know, some of the research that we've been involved in is large scale and really important too, in terms of everything from, you know, the impacts or the potential of a traditional diet to reverse diabetes in Aboriginal people through to UV filtration and air conditioning ducts in residential aged care facilities as a way of reducing the risk of transmission of respiratory illnesses such as influenza or COVID-19, through to almost anything you can imagine. We sort of getting our fingers into it because someone's got a passion or an interest. We have a group of PhD qualified mental health staff, for example, who we've employed them as mental health nurses. We didn't necessarily recognise that they had this research and academic capability, who have sort of found each other through the establishment of RACE and have established a journal club. And so a whole lot of interesting things happening on that front, really as an aside to, but in support of, the pursuit of excellence in providing health services. I'll talk very quickly about RMC Cares. So RMC Cares stands for Country Access to Remote Emergency Support, is our remote telehealth service for supporting emergency departments, smaller emergency departments in smaller communities when the GP who is in town either isn't in town or is unavailable or doesn't need to be woken up in the middle of the night for a simple presentation, but is still available if they need to be woken up for a complex presentation. And so what we do with RMC Cares is we actually use the emergency department at Riverland General Hospital, which is staffed with doctors 24/7. So there's always a couple of doctors there awake. There are trainees rotating in and out of the service doing their training program as well through RACE. As the hub for treating, for providing medical advice, two staff, advanced nurses, registered nurses in smaller locations on how to care for a patient that's presented in Panaroo, Lameroo, Karoonda or somewhere, in order to provide a backup to the local GP so that the service is sustainable. The trainees form a relationship with communities that they're providing support to, might actually do a rotation into that GP practice later on in their training program, and might even end up settling and becoming a local GP in that community, because RACE will train more GPs than our larger communities, and most of the training occurs there. So RMC Cares, has been established as a telehealth service across the whole region, and has at times also supported Whyalla and Port Augusta during the COVID response, where their medical staff weren't available because the medical staff had COVID-19, which was a bit of a challenge and is a bit like a minnow trying to swallow a whale in terms of the comparative size of the health services, but still managed to pull it off. Aged care, we have embarked on a process with Minya Residential Aged Care in Mannum, looking to transfer our role as a provider of residential aged care services in Mannum to Minya. So we provide a very small residential aged care facility in Mannum Hospital. It's quite dated in its configuration and would struggle to meet accreditation requirements in the longer run. Minya is a purpose-built large residential aged care facility in Mannum, literally straight across the road from the hospital. They've got a plan to build a 20-bed extension to their residential aged care facility and to relocate our residents into that new facility, brand new purpose-built facility, when it's eventually built. Plan's still in the process of going through all of the approval processes, and that's really Minya's business, and we are of course still providing care to our residents in the meantime. We have now also embarked on a community consultation, really planning process, looking at the future use of the space that's currently occupied by aged care in terms of potentially additional service space for inpatient beds, palliative care beds, potentially a rehab service or restorative care services. So that's quite exciting in terms of the future services for Mannum as well. And we continue to work on aged care strategy. There's a huge number of Commonwealth aged care reforms that have come out of the Royal Commission into safety and quality in aged care. Changes, even this month to the way residential aged care facilities are funded, introduction of the star rating, changes to staffing numbers and expectations around staffing numbers, and a whole lot of changes coming in the near future to home care, aged care services in the home as well. Peter discussed very briefly the fact that we have launched our Reflect Reconciliation Action Plan, and really that's the start of a journey as an organisation in terms of having a formal reconciliation action plan and a whole lot of initiatives about connecting the two cultures and making our services far more responsive to the needs of Aboriginal and Torres Strait Islander people. We have unveiled some large-scale artworks in the past financial year, one at Riverland General Hospital, more recently one at Barmera, and of course most people will be aware also in this part of the region of the one at the Emergency Department of Murray Bridge Hospital, which was unveiled a year before. We've launched an Aboriginal Health sub-brand featuring artwork by a Ngarrindjeri artist, Nellie Rankin, and you see that on the lanyard around my neck. And we've recruited hospital liaison officers and Close the Gap project officers, and really invested quite a lot in our strategic Aboriginal health team. We also were fortunate to host the launch of South Australia's Rural Aboriginal Health Workforce Plan here in our region. You can see some examples of the artwork and of course of the sub-brand and so on up on the slides. Peter touched on the change to the midwifery group practice model of care at Riverland General Hospital and more recently at Murray Bridge Soldiers Memorial Hospital. And you may have given away a little secret that we haven't really told the world yet about the plan to expand it also to Loxton Hospital. We have expanded our transition to professional practice program, so that's the program by which we support newly qualified nurses, registered nurses into their professional practice. And really we are now connecting that to the Riverland Academy of Clinical Excellence to try and have a far more holistic approach to the clinical workforce training. And we'll expand it to also include allied health as we go as well. So some big plans on establishing, expanding our approach to the Riverland Academy of Clinical Excellence to be the whole of the clinical workforce, not just the doctor workforce. And we have invested in a strategic asset manager position, developing our first strategic asset management plan, and have engaged in some master planning around some of our facilities like Tailem Bean Hospital and Murray Bridge Soldiers Memorial Hospital, really in terms of planning how we would grow them and adapt them in the future to meet changes in future population need. And I guess finally, we have a whole lot of different accreditation regimes that we have to comply with. Some examples of that are the aged care quality standards, the National Safety and Quality and Health Services standards, food safety standards, the National Disability Insurance Scheme practice standards, and we are forever going through accreditation processes. We have a program of unannounced visits with aged care, and some of them go well, some of them identify opportunities for improvement, and we are committed to working to improve our health services really regardless of accreditation findings in the pursuit of best practice. We do have our National Disability Insurance Scheme accreditation coming up at the end of this calendar year, so next month and the month after, November, December. And we also are starting to focus on the National Safety and Quality and Health Services accreditation, which is due in October next year. I reckon that's probably enough from me. I might hand to Craig.
Just when he was relaxing.
very much, Wayne, and good evening, everyone. My little part of this evening is just focused on the financial report, so I'll be very brief. Some of you may have a copy of the annual report, which is available on the little shelf as you come in the door. For those of you who do, the financial statements are featured in two places in the annual report. One is on page 37, where there's just a one-page at a glance set of financials, so a statement of comprehensive income and a statement of financial position, which is a really high-level snapshot of how we did for the year ended 30th of June. Included in those, in the annual report, also is a detailed set of financials that have been audited by the Auditor General's Department and signed off by the Auditor General. We've got an unqualified audit opinion again this year. So lots of pages of numbers and lots of details there, but I would refer you to those if you're requiring any more information on the financials, and of course I'm happy to answer any questions at any time. Just to touch on some of the major points of the finances for the year ended 21-22, we ended the year $6.7 million overspent against budget. Part of that was putting in $3.3 million to support changing emergency department medical models at Berry. We did have costs associated with responding to COVID of $6.5 million. As an entity, our total expenditure for 21-22 was $129.5 million, and we finished the year with $117.965 million in net assets. So that's all I was planning to share with you tonight. And I understand also that, Jeanette will correct me if I'm wrong here, we're actually not meant to distribute the audited financials pending to the highest level of government officialdom of signing those off, but we have leave from the Minister to share those with you more widely. So just a small point, but I thought I'd share. So unless there's any questions, I'll move on.
Okay, so we'll just open it up really to any questions that anyone might have. Any questions? Sharon, I thought you were going to ask one.
You covered it so well.
Wayne, we haven't heard anything about the Taylor Hospital law concerning extensions.
So the Friends of the Hospital did some fundraising, which acted as a bit of a catalyst for us to explore extensions. And then what happened was the Commonwealth Government did an MPS grant round, and they had up to $250,000 available for extensions. And putting those two bits of funding together, we sort of had maybe $350,000, $400,000 available. Then we did a review of, a master plan for Taylor and Bend Hospital in terms of what we want to do in terms of moving residential aged care to single bedrooms. Comes to about $1.2 million. It's still an active plan, and it's in a list of business cases that are being developed for aged care that will eventually go to the Minister. But it's not approved in terms of funding. We do need to do it to provide contemporary aged care services in Taylor and Bend. The facility's in a fantastic location and actually would make the world of difference to the facility. So it's still an active plan, if you like, but it's not currently funded.
So what would the time frame be as far as knowledge of whether it's going to be done or not?
So every year we go through a sort of a capital round in terms of when we might know when it will be done. I can't really put a time frame on it. There's certainly an active plan in terms of internal planning.
So it just stays in limbo for a definite period? Or does it drop off the end of the tracks?
Well, I wouldn't say drop off the end of the tracks. I'd say it's competing against things like a proposal to upgrade Murray Bridge Hospital, some planning around residential aged care facilities in the Riverland and so on, but it's absolutely still a priority, and it will be in the strategic asset management plan when it's developed, and that will probably give a better sense of time frame and what the competing projects are that in terms of funding priorities.
Does that money originally envisaged hang in the balance, or is that been
That's been and gone. We did
being
apply, but we'd never get, because it was only a maximum of 250,000 per grant, so we'd never get the Taylor Bean project done, or enough of it to do a sensible sub-project.
Yeah.
So, great question though.
So, in effect, Wayne, we're going to have to reapply if we do need those extensions to be done, because it's, at the moment, even though you're saying it's active, it's
So-
not.
So, it's on the list of LHN capital projects, if you like, that we would pitch if a funding opportunity comes up.
Is that like a wish list?
Well, it's a bit like a wish list, but actually there's a whole lot of things that have to be done. It's just a question of when and in which order.
Because the funding, I know some of that other funding that was against that has been returned until such time as the project can go ahead. And unfortunately, every delay there is, so the cost is going to go up. It was 1.2 last year. It could be 2 easily when it comes to be done.
Yeah, unfortunately
And that
that's...
makes it really hard, doesn't it, for a smaller... I know you're talking about upgrades to other larger regionals, but our buildings at Taylor Bend are really quite old
Yep.
and under depreciation in your finances and so forth. You know, it gets a point where they're almost ready to be written off instead of being patched up all the time.
Yeah, although I think in terms of the physical condition, Taylor Bend's not in bad condition. It's poorly configured
Yes.
because, you know, not all the rooms are single rooms,
No,
and really it needs en-suites throughout.
it does.
It's got some sewerage flow issues that would need to be sorted out at the same time. I actually think we've got a really great plan. The problem that we've got is it's $1.2 million that we don't currently have. $1.2 million isn't necessarily out of the grasp of the LHN in the right funding environment. It just depends on what all of the other priorities are and how they rank timing-wise.
What can we do to progress it?
Raising it here in front of the board's a good start.
I think so. It needs
But yeah,
to-
the LHN needs to finish developing its strategic asset management plan. Taylor Bend Hospital is a state government facility. It's more than likely needs state government investment, not just relying on the Commonwealth government. It's a multi-purpose service. The $250,000 grant opportunity that we chased was a Commonwealth government opportunity. Ultimately, part of it might come down to a political decision, or, like I said, it's not necessarily out of the reach of the LHN. We have about $700,000 of asset funding available each year that we have some control over. That means that in theory at least, $1.2 million is available over, that straddles 2 financial years. But it would be at the cost of, any investment in any other facility in those same years. So that comes down to the board having an endorsed strategic asset management plan and knowing where it fits into a program.
Thank you.
Any other questions? We are developing a strategic asset management plan. Michael, do you know about how far it will be before it goes in the board?
I believe it's going to go to the November board meeting
So-
as a draft plan.
As a draft, so
Yeah.
certainly, that bit of supporting strategy, if you like, is not that far off being endorsed for public consultation.
sure whether the local health network is the right forum to ask this, but about professionals being able to consult, well, I'll go back a step. If people have to go to have physiotherapy and some of the services provided by professionals, and they're living at Tintinara or they're living in Meningie or they're living at Canalpin, they're having to drive to the bridge and use the transport system for that. Is it possible for those professionals really to be encouraged to consult at the locations rather than the client having to be paying the extra, which is the gap that they pay for transport?
So
To
it's,
be
it's not a
travelling those
straightforward
distances.
question because it depends a little bit on who the provider is.
Yes, and that's
And-
why I
and
didn't know
the-
whether it was through
So
here.
it is possible for us to provide some of those services in those communities, both either face-to-face in an outreach sort of clinic environment, or by video conference, you know, supporting a client either in their own home or that comes into the Tintinara or Canalpin clinics to connect with our allied health staff if we're the provider of the service. But of course there are lots of private providers, lots of NDIS service providers, so it will depend a little bit on who the provider is and what their purpose of their appointment is, whether it's something that's, you know, falls within our remit as state government or whether it's, you know, primary health.
But I gather there must be some formula for a state that is a standard formula for the amount that is paid by the provider and then the gap that has to be paid by the client.
Yeah, so that sounds like it's a Medicare service, or it could alternatively be an NDIS service provided by a private.
So do we as rural organisations have any way of being able to impress upon those who are making those standards that it's not equal for people in rural areas because they're always having to travel further for these professional services than people in the metropolitan areas who are probably being subsidised at the same rate?
So yeah, that's really probably a Commonwealth government issue, and we can, you know, you can raise it with your local Commonwealth MP. Because it sounds like, you know, gap is probably them billing Medicare and charging a patient cap. Depending on what the person's health needs are, they may qualify for a service that we're providing Tintinara or Canalpin. Equally, if they're attending a specialist service that isn't available in those communities, they might qualify for the patient assisted transport service, depending on how far from home they're travelling to access the service.
I think there's probably more things that are follow-ups after you've had surgery and you've had some rehab or you need some physio or those little extra things. You're not necessarily seeing a specialist,
Yeah.
but you need to have those ongoing health needs for your well-being.
So follow-up after surgery, if it's public surgery, we would be providing the follow-up, generally speaking. And depending on the person's need, they might need to come to Murray Bridge, or we may be able to provide some of the support by telehealth to Tintinara and Canalpin. And certainly Brad here, not that I'm necessarily going to invite him up to the podium, but Brad, who's sitting 2 seats immediately behind you, could have a conversation about some specific examples.
It's just I've had the question asked by a couple of people in the community who feel that they're paying more as rural clients
Yeah.
than people who are in the metropolitan area where they've got those services closer than what we're getting.
Yeah, and like I said, it will depend exactly on what their health needs are, the level of specialisation of the service, whether it's something that a rural nurse could provide with some, you know, support and advice from a physiotherapist or an OT, or whether it requires a face-to-face consultation with a physiotherapist or OT. But, you know, we have a model, if you like, where a lot of clinicians, not only our own employees, but private ones as well, are still comfortable with face-to-face consultations at the consumer's cost in terms of travel time and so on, when in fact video conference or support of a different health professional that's closer to the client could actually save the client a lot of time and travel and time off work or away from the farming business or whatever.
Thank you.
Yeah. Any other questions? Do we have any questions online? No questions online. So give it a couple of minutes for anyone else that's got a question, and then I'll close the meeting.
Perhaps I could just interlude. Is there anything that you would like done differently for the next public meeting we have? We always struggle to find the best way for people to access us. Is that what we're trying to do? And we've chosen to come here today, and I'm happy for people to come. Does anyone can offer Wayne any suggestions you think about what we could do that would be better, easier and more useful? Be it now or at any time, just to email your thoughts through, because it will help us to work out how we can help everyone else.
I'm extremely concerned about the nursing staff issue. I think people doing 12-hour shifts and doing nurses is wrong. What we're doing that's creative, can we put an ad in the paper? Maybe someone at the Premiers or Flinders would like a 12-month sea change. Take 12 months leave without pay, come down. What are we doing? There has to be something else we can do over and above what other people are doing to bring them to our area. And I would like a brainstorming session and get people's ideas about how to be creative.
So we can certainly have a brainstorming session about the nursing workforce, bearing in mind that we are part of SA Health and that our recruitment is coordinated essentially through SA Health.
There may be someone that's burnt out in the
So-
city that would like to come down and just offer them a 12-month down here, something.
So certainly, I guess it doesn't help this week if you like, but we did open up 41 TPPP positions this year, which is a lot more than previously.
How's that going to be?
Well, hopefully we get some in Meningie.
Can they be left unsupervised? We're already a 1 hour.
No, they can't. You know that. But they, we need to be supporting local people into nursing roles, and even bringing more into Murray Bridge helps Meningie in terms of the availability of workforce and services.
It's got to end because it's just like we have no nurses here.
Yeah, and I guess that's a challenge that every health service in the state is facing post-COVID. We are advertising internationally. We're advertising in Adelaide. We're advertising interstate. But at the same time, every other state is also advertising in South Australia. If I open up Facebook, I see, Victoria offering $8,000 for a nurse to move to Victoria. And so that's a real challenge. I guess the other thing that we're doing that's perhaps, a little innovative, but it's longer term, is the stuff that we're doing with race around training pathways. But I agree, it's really difficult right now.
What do we do when our staff burn out completely?
Probably close the service.
And then what does the community do?
That's the challenge, isn't it? That's why we try not to close services. Ultimately, most of our staff are working because of their passion and enthusiasm for their community more than anything else. Happy to arrange a time for and a group of people for some brainstorming tonight, Lynn.
I think that one thing that we have struggled with brainstorming is actually not just the nursing staff or that level, but getting any staff at the hospital because of the restrictions around a lot of the advertising stuff. And I know that the hack can advertise in other places, but there's so
So-
much that seems to be so rigid throughout the whole health system, and I know it's not just something quickly in your local paper and get somebody in, and people don't even understand in the community that there are a lot of people that actually need care, but they need, the carer needs to have some qualifications. Maybe what can we do around getting information out into the community? There's a lot of non-information out there about carers, about access to carers, about getting to be a carer themselves and caring for someone else, and what qualifications they need, and where do they have to go to get them.
So
People
I'm
don't
certainly
know.
happy to, volunteer Susan to work on comms with the community about what's involved in getting into a health career
Yeah.
and what's expected. Because a lot of the hurdles at the recruitment phase relate to the need to get the right criminal history checks, and they're different for disability than aged care than acute care, which doesn't help either. And having the right immunisation status, everything from hepatitis to COVID-19, basically, depending on where in the health workforce someone's working. And some of that stuff, if you like, can be done in advance by candidates if they know what the requirements are. And the requirements is, all of state government requirements for the nursing workforce. So, someone that's training to be a nurse, it's worth getting that pre-organised for. We have, as recently as yesterday, Peter was lobbying the minister, and I was in the meeting where he was doing it, around the restrictions on our recruiting, advertising, and our branding and recruiting. Because at the moment we use the I Work for SA, whole of SA government branding, and that's mandated. And certainly we want to advertise as Riverland Māori Curong. We want to advertise on occasions as specific health services. We want to be a lot more local in the way we advertise local jobs and local communities, which is different perhaps than, how do we recruit nurses from Adelaide or from Victoria or from New Zealand?
But it's getting those local grown people that will hang around.
It's actually, getting them into a health career to start with. And bear in mind, health career can be anything from an Aboriginal liaison officer to a kitchen hand to a hotel, cleaning wards, through to, management, finance, CEO, ultimately, or, nurse, director of nursing, physiotherapist, OT. There's a huge range of different options, as well as, of course, the medical ones I mentioned earlier with Grace.
So was the minister happy to hear the discussion, or was he?
I raised it because it was a perennial source that irritates us. And someone said, if you advertise on the website in South Australia and happens to be a position for a nurse, when you click onto the website, there's 41, every vacancy known to man is listed. So you've got to go down 15 or 40 different things to find the right one. And no, it was pointed out how ridiculous it is. Now, to give him his due, he said, yes, I can understand that frustration. The new CE, Robin, I forget her surname to be honest, was there, and she was quite understanding and could understand this was silly in our state. We also addressed the fact that if we advertise today, it often takes 2 or 3, even 4 months before someone's employed. And the minister said, yeah, well, that's what happened to me. 10 years ago, I applied for Carlin, which is Central Adelaide, with the job. But he said they were so slow, I took one with Deloitte in the meanwhile I was waiting. So but it's the system of the whole of health and the whole of the bureaucracy we're trying to defeat. We're going to organise an officer to try and dedicate to help people to apply. And Wayne's point, if you think of any health involvement, if you get your vaccinations and your criminal health check out the way, you've cut probably 4 weeks waiting time off straight away. But we have to wait and see what the minister will do. He was positive, but we'll wait and see. SASH have had exactly the same problem. They've now come up with their own emblems because they want paramedics, etc. So we know the problem, we know it should be done, but it's a political hurdle at this stage. But he's a new minister, he would like to do things that are different. His comments were that he and Malinowski's government want to tackle the big things, not just the little things. So there's a lot of favourable statements, but we've been around life and politics enough to know that favourable statements tend to happen easily and don't always materialise into any practice. But let's keep an open mind and wait and see.
It's a start.
Yeah, and we meet with him regularly, and he's very accessible, so that's good.
So some other things that we're doing, but not for Meningi's as such, is the midwifery group practice change, so that midwives that want to be midwives don't have to be nurses on the ward as well as being midwives in places like Murray Bridge and Riverland General Hospital and Loxton and ultimately potentially Wakebury as well. So there are, some initiatives within our grasp, but the core problem in places like Meningi, absolutely keen to do some brainstorming and try and come up with some plans. And certainly, we can work with the HAC, I think, more innovatively around local education and advertising. So happy to have that conversation as well, Julie. Yeah.
Following on from that, Wayne, would it be feasible that you appear at one meeting mid-year? One of our meetings?
Yeah, or a member of my exec, because depending on the topic, it might be more relevant for Brad or for Louise, my Director of People and Culture, or one of the two.
I'm happy to turn up as well if that was going to be useful, provided I had a good understanding of what the questions were, what's going to be a sensible answer. To give you value, there's no point in me turning up and say I'll have to check all that out. That's frustrating.
Yeah.
So basically, as a board, we would like to be accessible to as many people as possible. Obviously, there are practical issues, and that's life. But within reason, if we can, Wayne also would like to be, or an exec person, Brad or whoever it is, who knows exactly. Because our role is to understand the community needs and wishes, to see how we can answer them. We can't always do it, but if we don't understand a concern, we have no chance to start.
Yeah.
So, yeah.
I mean, I'm only talking about once a year for one meeting,
Yeah.
and any of the executives, fine. But certainly things build up and we get virtually no feedback at the moment from the top.
Well, I'm sure we're very happy to address that, and as that if you want to carry on the conversation with Wayne, I'm certainly to be able to help in whatever way I can. So yeah, no, that's a very good point. We need for you to understand what we're doing.
Yeah.
Often we are, and maybe it's a lack of communication which you've identified. And I personally believe in life, majority of problems arise with communication problems more than almost anything. We can't give you every detail of everything we do every minute, but that's not what you're asking. So yeah, we'll keep that underway.
Good. Thank you.
And of course, the Don should be attending all of the HAC meetings, because most of the HAC issues tend to relate to the local health service relationship.
And Dawn does
Usually with the
attend
Dawn.
every
Yeah.
meeting, and she's very good, but there are some things that are out of her level of expertise as well. When it comes to, I guess, administration at the above level rather than administration at DON level.
Anything else?
Well, Wayne and myself, I'd like to thank you for being here and listening to both of us for some time, which is a bit arduous. But hopefully we've been able to answer some questions, give you an overview of exactly what all the complexities of what we're trying to do. But the thing, we can only do what we are informed about. If we don't have information, we're limited. So the message simply today is keep on informing us of anything that you think is relevant, and that helps us to discuss and digest at a board level a strategy about trying to deal with stuff. We can't solve all the problems, but we need to know and have a strategy and a plan to go forward.
Okay, thanks everyone.
And before you go, I'd actually like to thank you for, I guess, choosing us to have your public meeting here tonight. It's been a pleasure. I hope that the HAC have got something out of it. Thank you very much. And I'm glad you came. It's been an interesting night. So
Thanks for having us.
thank you.
Thank you for having